Dear audience, my name is Ioana Creanga-Murariu, and my PhD is about cannabinoids in the landscape of cancer. I'm an oncology resident and a bilateral PhD student from Grigore Tepopa Medicine and Pharmacy University in Iași, and here at Semmelweis University. My vision is an improved quality of life for cancer patients, and the mission is to decrease the disease burden in cancer patients. For this year, I have two specific goals. The first is to investigate the safety and efficacy of cannabinoids in cancer patients. The second is to investigate the antitumor activity of cannabinoids in preclinical models. I am planning to conduct systematic reviews and meta-analysis. So the first project, investigating the safety and efficacy of cannabinoids in cancer patients. As you all know, the cancer incidence is increasing. However, the mortality seems to be decreasing. By 2030, there will be more than 22 million cancer survivors. So quality of life is as important as an efficient therapy. Among the end-of-life care patients, 96% of them have pain. 90% lack appetite. 75% suffer from anxiety or depression, and 40% have nausea and vomiting. Of course, there are treatments for these symptoms. However, they can be inefficient for some kind of patients. So cannabinoids have promising results for palliation, but they raise some issues regarding a proper therapy indication. So my aim is to see whether cannabinoids are better than the standard of care for the palliation of cancer-associated symptoms. The clinical question is, are cannabinoids safe and more efficient by comparison to standard of care or placebo for the palliation of cancer-related symptoms? The population is cancer patients, intervention cannabinoids compared to standard of care or placebo, and the outcomes are efficacy and the symptoms: pain, nausea and vomiting, cachexia, mental alterations and quality of life, tolerability and safety. The hypothesis is that cannabinoids improve the quality of life and decrease cancer-related symptoms. The clinical implication is that we will have a new palliative drug and improved quality of life. We conducted a systematic search in 3 databases with a combination between the cancer and the cannabinoid domain. We could find some key articles which ensures that our project is feasible with both strengths and limitations. For example, in this article, the intervention had 2 arms, a combination between 2 active molecules, THC and CBD, and a THC-only group, and they assessed multiple outcomes that are of interest for us. However, the limitations come from the patients that are from different countries, and there could be some different approaches to background pain therapy. Another limitation is that the symptom intensity is patient-reported. For the second and the third key article, again, the same strength with multiple outcomes that are of interest for us. This time, the symptom intensity is recorded by medical personnel, and the same limitation with the large ranges for dosages in different countries. We started with more than 27,000 records, ended with more than 19,000 after duplicate removal. 551 studies were eligible based on abstract and title selection. And we ended up with 119 articles. Right now, we just started the data extraction. The second project is investigating the antitumor activity of cannabinoids in preclinical models. As you know, chemotherapy is still the preferred option for cancer treatment, but can cause life-threatening side effects and can become resistant to cancer cells. Cancer treatment costs are among the highest in the healthcare system, so alternative treatment options are always developing. Repurposing drugs with other indication is sometimes a cheaper strategy. So why not cannabinoids? The antitumor effect of cannabinoids were investigated in preclinical studies and in various cancer models. They can induct apoptosis, autophagy, they can have anti-angiogenetic properties, they can decrease invasion or metastasis. So the aim is to see whether cannabinoids have antitumor effect alone or in combination with chemotherapy. The clinical question is, Do cannabinoids have antitumor activity compared to controls in preclinical tumor models? The population is in vitro and in vivo tumor models. Intervention is cannabinoids with or without chemotherapy. Controls are without cannabinoids or chemotherapy, and the outcome is the antitumor effect, which means decrease in tumor cells or tumor volume. The hypothesis is that cannabinoids have antitumor activity compared to the controls. The research implication is that we will have a new anti-cancer drug and decrease in cancer-associated mortality. We did the same systematic search with the cancer and the cannabinoid domain. Again, some key articles, luckily they all have the same strengths and limitations. For example, they assess both the in vitro and in vivo antitumoral effects. They use human-derived cell lines, and they give a proper description of the antitumor mechanism. So in summary, I have 2 ongoing projects, both of them with cannabinoids. The first is to see their efficacy and safety for cancer-associated symptoms. The other is for their antitumor activity, and I'm planning to finish them both by next summer. Thank you, and do not forget, the harder you work, the more luck you seem to have.
We wish you a good luck with your project. Nevertheless, I have a question regarding your first project.
Yes.
How long the cannabinoids were used for the symptoms of the cancer?
For short term, the largest period was 2 months. But for an end-of-life cancer patient, I think 2 months is a reasonable time.
Because my question was whether there is a question about cannabinoid-induced hyperemesis, but in this case, I think it makes no sense to ask it.
Congrats on your presentation. I wanted to ask you how these cannabinoids are administered to the patient.
There are multiple forms for administration. They can be inhaled or orally taken or maybe topical. Of course, there are different pharmacokinetic differences in these forms of administration, and we plan to subgroup the patients based on this form of administration.
Thank you.
Thank you.
Congratulations, very nice and interesting talk. I would like to ask that, what do you plan to investigate? What kind of stage of the tumors and what type of tumors do you want to differ with these aspects? Or
we don't have a limitation. We want this meta-analysis to be as complete as possible. So we will include every stage of the cancer, every type of cancer, every localization. Maybe we will do a subgroup analysis if there is a logical meaning for that.
because your second project is based on, it's not only a palliative therapy, but a curative also.
Yeah.
So.
Yeah, there are some articles that cannabinoids are used not only for the end-of-life patients. However, the existing guidelines, oncology guidelines, allow the usage of some types of cannabinoids only for the patients that are at their end of life.
Congratulations. I was wondering, are there already approved cannabinoid-based products for palliative treatment?
Yeah, as I said, there are 4 types of cannabinoid already approved. They are all for chemotherapy-induced nausea and vomiting in oncology, but they are also approved in neurological disorders, for example, epilepsy or neuropathic pain that is associated with myasthenia gravis.